I'm going to show you a video now where I discuss threadbare my experiences with an intraoperative zonular dialysis and the management strategies. Here are a few cases of intraoperative zonular dialysis and the way in which they were managed. Now, managing a preoperative zonular dialysis is a planned event where the surgeon actually evaluates what is the extent of the zonular dialysis with a slit lamp, often aided by an ultrasound biomicroscopy. A strategy is put in place, and both the surgeon and patient are aware of what is the condition of the eye and what the possible outcomes are. As opposed to this, an intraoperative zonular dialysis is an unplanned event. It catches the surgeon by surprise. He almost always cannot tell what is the exact extent of the zonular dialysis. A new strategy now needs to be put into place, and thus all of this can result in a suboptimal end result. Now, this patient with a pseudoexfoliation, phacodonosis, and no obvious subluxation is a good candidate for a CTR. After achieving a pupillary mydriasis with a Malayujan ring and a rhexis, the surgeon now introduces a suitably sized CTR with a hand-on-hand maneuver through the main incision. The trailing eyelet is hooked on by a Sinskey hook and then rotated and introduced into the subcapsular space, after which it is released, giving good equatorial stability to the capsular bag. In this case, while attempting to remove the last fragment, the surgeon notices a downward flapping of the superior capsular bag, signifying a zonular instability. The surgeon attempts to put some viscoelastic, which results unfortunately in worsening of the zonular dialysis and a vitreous disturbance. The surgeon then introduces the CTR with a hand-on-hand maneuver, resulting in a progressive opening out of the capsular bag as demonstrated, after which the trailing eyelet is introduced into the subcapsular space and disengaged with the help of a spatula through the side port incision. Towards the end, the surgeon notices a peaking of the pupil, which signifies disturbed vitreous. Now, this is managed with a manual vitrectomy with a Varner scissors, and as you can see, the end result is a stable capsular bag and a nice round pupil. Whilst attempting epinucleus removal in this case, the surgeon notices linear folds in the underlying posterior capsule, for which he performs a viscofluid exchange. The surgeon then introduces the capsule tension ring in a hand-on-hand maneuver, and this technique of introduction of a CTR is a linear circumferential delivery of the CTR. The trailing eyelet is then hooked on with the Sinskey hook. It is introduced into the subcapsular space, and the point of release of the hook is such that the CTR's open ends come to lie at a place opposite the area of subluxation. In this case, the surgeon accidentally yanks the inferior capsular bag while attempting irrigation aspiration, resulting in a large zonular dialysis, for which he performs a fluid visco exchange and then introduces the CTR. Please note the CTR is always introduced from a point opposite towards the area of the zonular dialysis with a view of preventing it from getting worse, followed by its eventual disengagement and resulting in a nice stable capsular bag. At the end of a seemingly uneventful phacoemulsification, surgeon introduces the IOL, but accidentally pushes down on it, resulting in a large zonular dialysis. Now, this is merely managed by the rotation of the IOL to bring it to lie in such a position that the haptic comes and lies against the area of the weak zonules. In this case of seemingly uneventful phacoemulsification, at the end of nuclear emulsification, the removal of the instruments reveals the presence of a significantly large zonular dialysis. The surgeon insufflates the bag before introduction of the CTR. Please note the plane and the angle of entry of the CTR. It always needs to have a flattish angle of approach. Something too shallow would result in the angle. Something too deep would actually result in the capsular bag coming out upon itself. In this case, after a successful second chop, failure to disengage the probe from the fragment results in a significant zonular dialysis. The CTR in this case is introduced with a fishtail technique, which is a simple, safe, effective, and zonule-friendly technique of introduction of the CTR, which now negates the need of a circumferential delivery of a CTR, which has its own inherent issues. Now, here's how it's done. The capsule tension ring is flexed and held flexed with the help of a forceps. The apex is introduced through an unenlarged main incision and then comes to lie under the opposing capsular rhexis edge.
Then, turn by turn, one eyelet is introduced and released into the corresponding subcapsular space, resulting in a nice, stable capsular bag. The use of an injector for inserting the CTR allows for ease of insertion because it is directly inserted into the subcapsular plane. In this case of grade 3 nuclear sclerosis, after a successful second chop, the surgeon finds a difficulty, in fact, an inability in actually rotating the nucleus. Now, this is because of a zonular dialysis. The surgeon first performs a visco-BSS exchange and then attempts to put a CTR in the capsular bag with a hand-on-hand maneuver. However, halfway through its insertion, surgeon finds an actual difficulty in putting in the lens. In fact, the zonular dialysis has got worse and the nucleus is tilted. So surgeon now offers stability to the capsular bag with the help of capsular hook that actually pulls the bag up, after which he very easily and comfortably is able to introduce the CTR into the capsular bag. Having achieved that, the surgeon now very carefully and comfortably completes the nuclear emulsification, the introduction of the IOL in the capsular bag, the removal of the capsular hook, and an optimal end result. So what has been my learning through this? In patients with an intraoperative zonular dialysis, as you can see here, the mere introduction of capsular hooks to stabilize the bag may not be adequate because you can't really tell how extensive the zonular dialysis was. So in this case, the surgeon has actually introduced only capsular hooks to stabilize the bag. And despite a very careful emulsification up to the very end, because of lack of equatorial stability, the entire capsular bag was emulsified, and then there was a significant problem to deal with. So, what my learning really is that when you have an intraoperative zonular dialysis, yes, you go ahead and put capsular hooks to stabilize the bag, but in addition to that, introduce a CTR as well to give you that equatorial stability of the capsular bag and a stretch to the capsular bag. So at the end of nuclear emulsification, you have a bag that's absolutely stable and bang on in place. Now, this patient with a soft cataract had a zonular dialysis during nuclear emulsification, for which the surgeon introduces a capsule tension ring as demonstrated. However, after its introduction, if any part of the capsule tension ring is still visible, it signifies a decentered bag which now requires additional support. In this case, the additional support was achieved by the scleral fixation of a capsule tension segment. A capsule tension segment can also be introduced in a phakic eye with the view of stabilizing a subluxated capsular bag. The CTS can be introduced through the main incision, slid under the rhexis, placed at its proposed point of fixation, after which a capsular hook, as you can see, hooks onto the central eyelet and is pulled outwards and stabilized thereafter. Now, what you achieve with this is a very high level of stability of the capsular bag, which allows for ease of subsequent nuclear emulsification. At the end of nuclear emulsification, one of the straight needles connected to a tenoproline suture is passed through the central eyelet of the capsule tension segment, and this is kept ready outside the eye. The capsule tension segment is now introduced into the eye through the main incision, and it is introduced into the capsular bag and comes to lie at a place at the proposed site of scleral fixation. One of the two needles connected to a tenoproline suture is now introduced into the eye at a point opposite the area of the proposed fixation, and it is railroaded and exteriorized with the help of a 26 number needle to come to lie in a shelved groove made 1.8 millimeters behind the limbus. The two needles are cut and the suture ends are pulled out and tightened, and the extent of tightening such that it causes a well-centered bag.
Can we have the lights, please?
Here are a few cases of intraoperative zonular dialysis and the way in which...
Thank you. We can get to the next slide. Right. Any questions? It's just to compile a few cases that I worked with. No? All right. So, Subin, would you introduce the next speaker? Are there any questions in the audience? Or then, yes.
Showed the second technique of inserting inserting the CTR ring, no? So can it be used for superior dialysis also? Like you made a loop and then inserted it.
So fishtail is not as easy as it looks. I'm sure everyone here will agree. It does work, but the challenge in that is holding it in its flexed position and maintaining that flexed position while it enters into the eye. So I don't use it for superior subluxations. Once in a while, if I've got a significant inferior subluxation, or if there's a subluxation which is inferior, which is like 3 or 4 clock hours, and I'm a bit concerned that when I put it in a hand-on-hand maneuver, I might make the Zondler dialysis work. It is in a case like that where I would consider putting in a CTR with the fishtail. Otherwise, with a hand-on-hand maneuver, almost always it works well. Sometimes when you're putting in a CTR with a hand-on-hand maneuver, you're looking at a rigid PMMA device. We are looking at a device that is about 11 millimeters in its diameter. We are aiming at introducing it through a rhexis that is 5.5 at an angle that goes between the inner lip of the wound, then through the rhexis, then into the bag, and you're rotating it around. It's a question I've often asked. Should you go this way or should you go that way? I think either way it could actually be a little bit of a compromise, and there's no telling that you're never going to necessarily have an absolutely brilliant result. Just one take-home message I'd like to give you is that I always, now what I do after I made this is that I add a little bit of a cohesive viscoelastic to create a space between the rhexis edge and the nucleus to allow for ease of insertion of the initial, the leading eyelet of the CTR. वो अंदर चला गया ना, and then if you don't let it slip back, it's going to go into the bag. So that's the other challenge. If you can't see and you end up with one in the sulcus, then it's hell to try and bring it out and sort it out. And moreover, you then no longer have a CTR in the capsular bag, and you don't have a stable bag to carry on with your procedure. And finally, I think I would, once I see a Zondler dialysis intraoperatively, I will always put in a CTR then and there and not at the end or not at any other time, because once I've created a Zondler dialysis, for me to be able to safely complete the phacoemulsification uneventfully, I would want to achieve and I would aim to achieve a stable capsular bag for the rest of the surgery, which only a CTR is going to give me.
I think Dr. Suvira very well presented most of the important points you brought out.
Yeah.
I just wanted to bring another specific issue to the
students
focus of the audience.
Yes.
Is sometimes these eyelets they don't have uniform diameter, and when you are dialing in the end of the CTR, it gets stuck. The Sinskey hook, and there is a mismatch in the size, it gets stuck. So you need to have another second device, another Sinskey hook to disengage it. So sometimes it has happened, you're stuck inside, it doesn't come out. So you should have always the second Sinskey hook available.
So I tend to introduce a CTR through the main incision, and the trailing eyelet I introduce with a McPherson's with its convexity to the left, like how we used to put in the rigid 5 mm, 6 mm lenses. With that, I maintain a very good hold, or kuch bhi ho jaye, it doesn't leave, it just goes.
Yeah, I mean there are so many ways of implanting it, but this is one of the problems that I've encountered.
Couple of comments about the fishtail technique. Now, one is the incision size was a little larger than usual. Second, should be very mindful of the type of CTR that you're using and the manufacturer. There are different types of PMA. If you use the Madhu Instruments one, it's a very flexible CTR. You may probably be able to do a fishtail. If you're using an APA or Orolab, you're going to break it. So be very careful. If you're not very confident with the fishtail one, I'd rather go the conventional.
See, I always hold the trailing eyelid with a micro rhexis forceps.
Great.
It goes in through a 1.5 incision, and you can place it directly at the rhexis margin and then leave. It goes in completely.
The control on holding it is a lot more with a forceps than with a Sinskey.
One small comment about the micro rhexis forceps or any micro forceps that you use. I've had this nasty experience and presented as a challenging case once. Is that if you're using, preferably use titanium ones. If you're using slightly oldish one, steel ones, the sleeve, if it's split, you see it can lead the jaws to lock, and don't leave the eyelet till the end, and when you're secure that you're going to leave it and it's going to go on its own and not going to come back at the end of the jaws. You see the jaws are open like this, the sleeve is over here, okay? Now you let it go, and by the spring action it comes and recoils, it gets stuck in the jaw. Now you can't release it, you can't do anything, you're stuck. I was stuck with a CTR like that, and then I had to break that eyelet and then let that CTR go because I was, no way, I couldn't go in, leave it, I couldn't come out. So be very careful. It happens with the steel ones. Use a titanium one, doesn't cost a big deal these days.
Thank you. Thank you, Dr. Subin. Thank you all.